A warm good morning to all. Wishing you a green and eco-friendly World Environment Day. This would be the ideal day to create an awareness about the various aspects of ecopharmacology. So we, the Department of Pharmacology, Government Medical College Kottayam, welcome you all for the national webinar on ecopharmacology, which is also organized as a part of this college Diamond Jubilee Year Faculty Development Program Series. Pharmaceuticals are life-saving remedies to mankind, but when their residue remain in the environment, there will be a negative impact on the ecosystem, which was never thought of.
Ecopharmacology, otherwise called as environmental pharmacology, is the effect of pharmaceuticals and healthcare products on the environment and ecosystem. The term was coined by Holling Sorensen in the year 1998. It is relatively new and emerging specialty of pharmacology, which involves the study of gene environment, drug environment, and toxin environment interaction. Environmental issues caused by pharmaceutical pollutants had received increased attention with continuous rapid development of global pharmaceutical industry.
This webinar discusses the disastrous effects of pharmaceuticals made to ecosystem and the solution to this pollution.
Without any delay, let's start the first talk of the day on ecopharmacology, Where Do We Stand Now? By Dr. Harishankar K. Assistant Professor, Department of Pharmacology, GMC Kottayam. Dr. Harishankar K. MBBS, MD Pharmacology, Assistant Professor, Department of Pharmacology, GMC Kottayam. He did his MBBS and MD from GMC Kottayam. He's the Deputy Coordinator of Pharmacovigilance Program of India, also a member of Antimicrobial Stewardship team in the institution. He has done publications in various reputed journals. Over to you, sir.
Good morning, respected teachers and my dear friends. So today we will see some introduction about the ecopharmacology. As we know, we should have a give and take policy to the environment. Actually, what happened is we take only. We predominantly do take only. So what happened is it destroyed most of our environmental system. So we will see how these environmental systems were damaged by our activities. So direct and indirect activities are there. So direct activity, we know deforestation, etc. And indirect activities, we will see how these indirect activities. One of the important indirect activities is happening through our drugs. That means the pharmaceutical products. So personal care and pharmaceutical products contribute to environmental damage. And we'll see how this is happening. Now, pharmaceutical and personal care products are upgraded as PPCPS. So, what is happening with this? So, human and veterinary drugs and also various products in treatment and therapies of these. Then dietary supplements, various kinds of dietary supplements, consumer products like fragrances, cosmetics, sunscreens, laundry products, etc. Actually, we ignore these, but these contributes to a large number of environmental problems. Then all other non-main ingredients in these products, such as polychlorinated diphenyls, perfluoroalkyl substances, then polybrominated diphenyl ethers, etc. These can alone or in combination, these can produce a lot of damages in the cells. Now, how these pharmaceutically active compounds enter into our system? Now, first of all, industrial pollution. Industrial pollution is the waste from various pharmaceutical industries contribute Then human. How human can produce this pollution? One, disposal of these pharmaceutical and personal care products. Then excretion from human bodies. That means pharmaceutical products in human use and in veterinary use have two lives. Then veterinary products, it can be from aquacultures, etc. Then animal excretion. Then agriculture related products. So agriculture and food. So production of food and agriculture production produces a lot of chemicals. And chemicals used for this enhance the production in the agriculture field and animal feed contribute to environmental pollution. Now, all these can find entry into the air, soil, and surface water. So the fumes will enter the air, the liquids and solids can enter the soil and surface water. So what happens is cosmetic and personal care products also can contribute, and they can directly enter into the surface water predominantly and to soil also. For example, if we have sunscreens applied for cosmetics like lipsticks or perfumes, body sprays, etc., and we are taking a bath, it will enter into the aquatic system. Now, this it can ultimately pollute our groundwater, and this can come back to the surface water. So this is the cycle. So air, soil, surface water pollution, it can lead to groundwater pollution. This groundwater will come again to the surface. So this cycle continues. Now, this is what I have told. There are two life for pharmaceutical and personal care products. So one, if we are disposing it, and second one, even if we are using it, it will get excreted. And some of the important excretion, some of the drugs which the excretory products can contribute to the environmental damages. Some of these, for example, if we are taking into this atenolol antihypertensive, which is 90% excreted unchanged to the kidneys, and sometimes it can find entry to the environmental system. Now, today we celebrates the World Environment Day, and this is the 50th anniversary of the World Environment Day. And this time, the slogan is hashtag beat plastic pollution. So this was one of our inspiration to do this webinar. Now, first we will see some of the important environmental hazards or environmental effects we found by this. In 1976, Kansas City, USA, and in 1994, Berlin, Germany, a lot of chlorfibric acid or fibric acid derivatives was found in the soil or found in the water. And this contributed to, and a study was conducted how this can adversely affect the system. So it found out that zebrafish study showed reduced fecundity and embryo anomalies in them. And later in England, the surface water, the rivers of England were contaminated by estrogenic compounds. It was early detected in 1980. And also later, so the estrogenic compounds produced vitellogenin in animals, and this vitellogenin can contribute to transgender fishes. So the famous river Thames is now have a lot of pollutions. And in 2001, it showed that hyperactive eels, the eels get hyperactive, and it was found out to be because of cocaine contamination in the rivers of the England. And later in India, we have a lot of examples in India also, and we found out that in 2004, there is a lot of death of Indian vultures. And what happened is it was because of indiscriminate use of NSAIDs in animals or in veterinary medicines. And the predominant NSAID was diclofenac, and this diclofenac, when found into the vultures through the eating of carcasses, produced renal damage in the vultures and accounted to the death of vultures. And it's shown that the Indian contamination of carcasses was up to 10%, and even 1% contamination can lead to 80% reduction in the population. So we can think about how much dangerous it was. So some restrictions was there in use of NSAIDs in veterinary practices, especially diclofenac. Now, another incident in India was rivers of Pattancheru. Pattancheru is a village in Hyderabad. Because of the rapid development in the pharmaceutical industry there, in 2009, one environmental survey was conducted and found out that there was a lot of contaminants were there in the rivers of Pattancheru. And one of the important contaminant was ciprofloxacin, and the concentration of ciprofloxacin was very high. so that it produced a lot of antimicrobial resistant organisms in the water. Now, another incidence was ivermectin use in cattle. So the ivermectin was used for deworming, and this is coming into the dung, and the dung beetle was got inappropriate effect in the dung beetle. So the ivermectin residues produce reduced growth and growth inhibition in the dung beetles. Now, another famous problem, which or the notorious problem, we found out that fluoxetine in the water. So the increased content of fluoxetine in the water produced hyperactivity in shrimps. Usually, shrimps prefer dark environment, but in the presence of fluoxetine, even the lower concentration of fluoxetine, the shrimps were hyperactive and they swam towards the light, and this produced increased predation. So the number of shrimps were reduced because of the high fluoxetine content in the water. Now, another problem, we found out that the presence of levonorgestrel in the fluid or in the water was produced alteration in the sex hormones. So it led to sterility in female frogs. So the exposure from the tadpole itself, when the tadpole develops into the frogs, they were sterile because of the increased concentration of levonorgestrel. Now, finally, we'll see some of the human impacts also. Now, the crystalline silica, the exposure to crystalline silica was associated with a lot of autoimmune diseases, especially ANCA vasculitis, SLE, systemic lupus erythematosus, and rheumatoid arthritis in human. Now, endocrine disrupting chemicals produce precocious puberty, testicular, and breast malignancies in human. Then maternal exposure to polycyclic aromatic hydrocarbons produce serious breathing problems in children like bronchial asthma, etc. The echo shadow is another field where human impact is seen as environmental impact of antibiotics is known as echo shadow. We will see this in the upcoming presentation. So what is the solution for this possible risk? Now, the ultimate solution is going back to nature. But at this stage of human civilization, it is not completely possible to entirely going back to our environment. So what we can do? So we started learning about the possibilities. So the learning or the study subject or the study fields are ecopharmacology, environmental pharmacology, and pharmacovigilance. Now, pharmacovigilance is the upcoming, and it shows the science and activities pertaining to detection, assessment, understanding, and prevention of adverse effects or other problems related to existence of pharmaceuticals in environment. Now, other ecopharmacology all can contribute to some of the studies about these adverse effects. Now, how this impact can be reduced. Now, one suggested solution by FDA was environmental risk assessment. FDA is now stringent about a study which will contribute to reduction in the impact. So FDA now mandates that the environmental pollution by a new drug or a drug should be less than 1 part per billion. Now, another risk mitigation strategy is to identify the risk quotient. Now, the risk quotient, we will show that the predicted environmental concentration, which will be divided by predicted no effect concentration. So, if it is more than 1, it will contribute to more environmental damage. Now, another is Resource Conservation and Recovery Act. It regulates and tracks disposal of solid waste. Now, another important report or another important study which was done by 5 European countries, namely Germany, France, Luxembourg, Netherlands, and United Kingdom. And this study was No Pills report. They will predominantly concentrating the pharmaceutical products in water pollution, and they came out with some 9 recommendations. Now, what are their recommendations? First one they recommend is the Green Pharmacy Protocol. Second one, the collection schemes for unused medicinal products should be improved or should be started if it is not started. Then developing source separation, wastewater treatment, etc. Then information and education activities for public and professionals so that the other activities can be increased. and prioritizing and monitoring of molecules and or environmental compartments of concern. Then consolidation and transparency in information. That means these what all things have happened, this information should be transparent enough to be accessed. And ecopharmacovigilance network should be strengthened and implementing incentives for doing these kind of environmental activities. Then research-based knowledge to enhance the facilitations in this field. No, these are the references of my presentation. So I hope this was an introduction and some points you might have got from this presentation. And already there are a lot of PowerPoints which was shared in the group. Now, our slogan for this year's environment is beat plastic pollution. And if you can't reuse it, refuse it. So we all can join this hashtag moment and try to reduce our plastic use in our life. So thank you all.
Thank you, sir, for your crisp presentation, which provided an overview regarding the concept of ecopharmacology. He rightly pointed out its environmental and human impacts and the possible mitigation strategy. It was really an informative session, sir. Since we have a tight schedule, we won't be taking any questions now. Kindly note down your queries and mail to pharmacologykottayam@gmail.com. We'll be forwarding it to the concerned resource person. And also note, kindly do not share your screen as to interfere with the presentation of the resource person.
Now, I request share. അത് കാണാൻ പറ്റുന്നില്ല സാറിന്റെ കാണാൻ പറ്റുന്നുണ്ടോ ഇല്ല ഷെയർ ചെയ്തിട്ട് Now, I request Dr. Abdul Ghafoor sir to present the topic, why did our country ban colistin use in livestock? Dr. Abdul Ghafoor, MD, MRCP, FRC Path, is a consultant of infectious disease, Apollo Hospital, Chennai, coordinator of Chennai Declaration on AMR, and he is also the managing trustee of AMR Declaration Trust, managing partner of Quorum Veda Consulting Service. He is active in the academic and the policy perspectives of AMR. He has widely published in Lancet, BMJ, and other well-established journals. He's a jury member of Longitude Prize on AMR. We welcome you, sir. Dr. Abdul Ghafoor sir will be joining us in 5 minutes. I would like to request Dr. Vijay to stop sharing.
Hello, can I talk? Okay. Hello, good morning. Hello, am I audible?
Yes, sir.
Sir,
You
yes,
are
sir.
audible.
Yes.
Yes.
The antibiotic usage in the veterinary practice is much more than the antibiotic usage in the human world. 70%, 70% of the antibiotic manufactured by the global pharmaceutical industry is consumed by animals for growth promotional purpose. When we say growth promotional purpose, it's not for treating infections, not for prophylaxing against infections. It is to make the animals grow fat and fast. All countries use or follow the growth promotional usage of antibiotics. It's regulated in many countries, especially many European countries. The countries like Sweden and Denmark have been the leaders in efforts to control the veterinary antibiotic usage. Somebody has posted PowerPoint is not visible. I'm not using PowerPoint. I'm not using PowerPoint. That's why the PowerPoint is not visible. Countries like Sweden and Denmark have made significant advance in controlling antibiotic usage in the veterinary practice. Still, many European countries, US, and many other countries, including India, the veterinary antibiotic usage is rampant. And that veterinary antibiotic usage is making significant contribution to the AMR in India and other countries. The veterinary antibiotic usage is one of the important causes of antimicrobial resistance in humans. It's scientific, it's proven. The animal-human link is proven. That's why we call it is the One Health approach. If you want to control antimicrobial resistance in humans, we need to control the antibiotic usage in animals, in aquaculture, in agriculture, because antibiotic usage is rampant in animals, in aquaculture, and in agriculture. I'm an infectious disease physician. Most of my patients are cancer patients. 90% of my patients are cancer patients. I treat infections in cancer patients. My specialty is treating infections in cancer patients. And cancer patients are the most immunocompromised people you can ever come across. Infections in these patients are severe with high morbidity and high mortality. Cancer patients have got high antimicrobial resistance rate. Because by the time a patient comes to a cancer hospital, that patient has visited several doctors, several hospitals that carry drug-resistant bacteria even before getting admitted to a cancer hospital. When I did a study a few years ago, 1/3 of the patients coming to my hospital referred from other centers. At the time of admission itself, their intestine, their stool is colonized with carbapenem-resistant bacteria. That means 1/3 of the patients at admission itself is carrying carbapenem-resistant bacteria. I did a study recently. We did the study 2016. 7% of the healthy young people in Indian metropolitan cities are carrying carbapenem-resistant bacteria in their stool. These are healthy volunteers, not patients. So we have got a high community prevalence of carbapenem resistance. And the patients, of course, the carbapenem resistant carriage rate will be much higher. So you are dealing with a patient or a population with high carbapenem resistant gram-negative rate even before they come to you. And when these patients become septic, the chance of that gram-negative bacteria in the blood is very high. So the probability of an oncology patient in any of the Indian oncology centers or many other countries, and not just oncology, many other patient population, especially with the comorbidities, the chance of that patient's bacteria causing sepsis to be carbapenem resistant is very high. And the drug of choice is colistin. Colistin is the mainstay of treatment in carbapenem resistant bacterial infection. If the bug is colistin resistant, the chance of that patient dying is very high. So we are very careful in using colistin. We are very careful in starting colistin. We are very careful in stopping colistin. We are very careful about the dosing of colistin. We are very careful about the PK/PD of colistin. We are very careful about the side effects of colistin. Colistin is the holy water in treating patients with severe sepsis, especially in immunocompromised population like the cancer transplant patients or patients in intensive care units. In countries like India and several other countries where carbapenem resistance rate is very high. You will be surprised to know that the same colistin, the same holy water in hospitals in India and several other countries, the same colistin is fed to animals, fed to poultry, fed to fish in aquaculture and the poultry farming. They mix colistin in animal feed, they're feeding to poultry and fish to make them grow fat and fast. So our holy water in the human world is considered as a feed additive in the farming industry. And that's creating resistance in animals. And that resistance is being spread to the humans, including healthy humans. In 2018, I did a study. I collected 100 food samples, poultry and vegetable samples from Chennai, because that's where I work. And what I found was 50%, that means half of the food samples are growing colistin resistant bacteria. I collected the sample from Chennai, but it's applicable to throughout the country. If you can test food samples from anywhere in the country, it will be 50% colistin resistant. Not today, I'm talking few years ago. Today, the situation may be different because of something else happened after that. So 2018, half of the food samples were having colistin resistant bacteria. Now, are these colistin resistant bacteria similar to the colistin resistant bacteria we come across in the hospital? No. In a hospitalized patient, once the bacteria is colistin resistant, that is resistant to almost every antibiotic, including carbapenem. A colistin resistant bacteria in hospital or patients will be carbapenem resistant and resistant to most other antibiotics. Now, when you test the colistin resistant bacteria in the food, it will be entirely different phenotype and entirely different genotype. They will be colistin resistant, but they will be sensitive to most other antibiotics, including cephalosporin. That's how you differentiate whether a bacteria, a colistin resistant bacteria, is from a food source or from a human source. A human colistin resistant bacteria will be resistant to everything else. A food colistin resistant bacteria will be sensitive to all other antibiotics. Because this bacteria, this colistin resistant bacteria in the food is originating from animals, especially poultry, where colistin is the most misused antibiotic as a growth promoter. Yes, they use other antibiotics. They use several other antibiotics. You will see some resistant to cephalosporin, some resistant to doxycycline, and certain other antibiotics. But colistin resistance is the most universal. And we can easily differentiate where the source is. The animal source, that will be resistant to colistin, sensitive to most other antibiotics. And we did a gene sequencing study. You will see the difference between human resistance, colistin resistant bacterial clones, and the food and animal clone. They are entirely different. They are entirely different. So if a food bacteria is colistin resistant, we know that's a food source. And the human one, the bacterial clones are different. But there is a connection between the colistin resistance in the food bacteria and colistin resistance in the human gram-negative bacteria. As we know that the resistance in the bacteria can be in the plasmid or in the chromosome. We all know that if the resistance is situated in the plasmid, a plasmid resistant gene can very easily be transmitted to other bacteria through the bacterial conjugation. Anything in the plasmid jump quickly to other bacteria, same bacteria and to other bacteria, from one patient to another patient, one ward to another ward, one hospital to the community and to the other hospitals. Plasmid, for example, extended spectrum beta-lactamase is a plasmid gene. 70% of the Indian gram-negative bacteria are ESBL producers. It's because it's situated in the plasmid. Now, if a colistin-resistant gene is situated in the plasmid, it's very easy to spread. But majority of the colistin-resistant bacteria in humans or in the hospital, the resistance gene is not situated in plasmid. It's situated in chromosome. So how does it spread? Chromosomal resistance doesn't spread easily through the conjugation. So how do they spread? So a few years ago, maybe 10, 15 years ago, we all believe the colistin resistance in the hospital, the bacteria colistin resistant will not spread fast because in the chromosomal. We were proven wrong, and today colistin resistance is increasing across the world. What happened was, in 2013 and 14, scientists found that even chromosomal colistin resistance can spread from one patient to another because there's something like insertion sequence gene. Insertion sequence which get inserted into the chromosome, take the colistin resistant gene, get inserted into the plasmid, and once inserted into the plasmid, it can spread easily. And 2013-14 itself, especially Italian and Greek scientists found that that's how the colistin resistance is spreading. The chromosomal gene, the most famous gene is MGRB, MGR gene. That's the most common colistin resistant gene in the chromosome. It's spread through insertion sequences, get inserted into the plasmid, and once it's in the plasmid, the job is very easy. In 2015, a major publication appeared in the Lancet. There's a plasmid gene called as MCR gene, and that is so common and spreading in animals and food. One of the most common colistin resistant gene in Western studies in the food and animal sources, MCR. But the problem is, majority of the human colistin resistant Klebsiella, there's no MCR. I haven't seen MCR in human population. The majority are MGR or other chromosomal mutations. So the presence of MGR, we know that MCR spread fast in the food source because it's plasmid. But my bacteria are chromosomal resistant. So I'm not really concerned about, there are hundreds of papers published in the literature on the presence of MCR gene in the food source and animals, and that is spreading to animals. Yes, anything in the plasmid through the food will spread to humans because it's plasmid. But unfortunately, that did not give me an explanation because my bacteria, my human bacteria, are the colistin resistance gene in chromosome. So I was looking for an explanation. So when I did the colistin resistant food study in Chennai food sample, my scientists looked specifically for colistin resistant genes in the chromosome. And of course, we found it in the chromosome. But then we look for the insertion sequence gene that were earlier identified Italian team in 2014. And then the whole scientific community forgot about the insertion sequences and MGRB gene mutations because they were obsessed with MCR, which has no clinical relevance to me. So my team looked for MGRB gene insertion sequences in the food Klebsiella, in the Chennai food samples, and we identify exactly the same gene in the food Klebsiella, exactly the same insertion sequence in food Klebsiella. And we proved the additional food link of colistin resistance. Then we analyze colistin resistant bacteria in the hospitalized patients. And you will be surprised, a very large percentage of hospitalized patients are having colistin resistant bacteria in the stool. So you will immediately believe that's because we're using colistin in the hospitals. So we analyze the colistin resistant genes and the phenotype in the stool samples of hospitalized patients. We are shocked to find that majority of the colistin resistant bacteria in the stool samples of hospitalized patients, they were not hospital colistin resistance pattern. They were food colistin resistant pattern. They were sensitive to majority of the antibiotic and resistant to colistin. There were very few, a minority of the patients had the hospital colistin resistant bacteria phenotype, which is resistant to most antibiotic, and the genotype and the clone pattern is different. So even in hospitalized patients, the source is the community food. Then what I did, I had to prove the link further. So we analyzed last year, actually 2019, not last year, we published last year, 2019, we collected human healthy stool samples, and we found 14%, 14% of the healthy volunteers in Chennai were never been to hospital, never took colistin, they're having colistin resistant bacteria in the stool. We analyzed the phenotype and genotype, we found that there's a food source. So 14% of the healthy volunteers are growing colistin resistant bacteria from the food source. Every day we eat colistin resistant bacteria from our food. Every day, majority of our gut is colonized with colistin resistant bacteria in the food. And we know that there is a gene transfer from the food bacteria to human bacteria through MCR plasmid gene or MGR in the chromosome with the help of insertion sequences. So there is a very strong link. My team gave the additional proof for the food to human transmission of the colistin resistant bacteria. We are convinced that the colistin resistance that's happening in the human world is strongly linked to the colistin usage in animals. And that was a time I was a member of the National Antibiotic Policy Committee. In 2000 itself, when we got the food data, I communicated with the government, and I have to say that we have to use every political strategy to get the colistin usage in animals banned. And you will be again surprised to know that 90% of the colistin usage in animals as a growth promotional is imported from China. And China has banned the colistin growth promotional usage in 2016, and still our farmers, our veterinary pharma lobbies were importing it from China. So what we did when I communicated with, because once we get a data, you have to act on that data. I try to convince the government trying to talk to the diplomatic route through the Chinese embassy. They told, we have banned it. It's your farmers are importing it. We can't do anything about it. You are importing, you just ban it. Then we have to follow every political strategy to get the colistin banned in the gross promotional in the farmer. Because you know that Indian poultry industry is a 100,000 crore industry, 1 lakh crore industry. It's a huge industry. And colistin is a very important growth promotional. It's very cheap and wonderful growth promotional agent. They put every pressure against the ban. Finally, we did the colistin ban in 2019. Currently, I don't know the exact colistin usage in the poultry in India. I haven't followed up, but I'm sure there's an import ban and the colistin usage has significantly dropped in animals. And now if I do a food colistin study, there's no study after that in India on colistin food samples. And if I do a study now or anybody else study in the study, I'm confident that the colistin resistance will significantly come down. Even my healthy volunteer study of 14% was done in 2019, just around the ban. I'm very interested in doing a follow-up colistin resistance in the food samples and healthy human volunteers and hospital stool study, again as a follow-up to analyze the impact of the ban. Let's not forget that we cannot tackle antimicrobial resistance unless we tackle the antibiotic usage in animals, in poultry, in fish, in aquaculture, in agriculture. Luckily, we don't have organized pig industry. We don't have organized cattle industry, cattle farming. Yes, we have got to organize cattle industry, but we don't have organized cattle farming. We don't organize pig farming, but we have got a very, very powerful organized poultry farming, pig farming, and agriculture. We need to get the antibiotic usage in animals, in fish, in agriculture banned. Every antibiotic. It's not easy. We started with colistin. One by one, we can get other antibiotic banned, but it's going to be a huge, huge task because farmers, they believe they need antibiotic, and it's very difficult to get other antibiotic usage banned. But somehow we have to get it done. Thank you.
Real experience and the practical knowledge override the theoretical understanding in any subjects, especially in medical field. Sir was the coordinator of famous Chennai Declaration, which actually paved a way for tackling the antibiotic resistance in India and a stepping stone for making a national policy for curbing the same. Thank you, sir. It was indeed enlightening session from an experienced scholar. Thank you, sir.
Now, I invite our Honorable Principal of Government Medical College, Kottayam, Dr. Shankar sir, for the inaugural speech.
Good morning, everybody. Am I audible?
Yes, sir.
Thank you so much. Today, as you all know, is the World Environment Day. And not only that, our college, Government Medical College Kottayam, is celebrating its Diamond Jubilee year in 2023. So it is a very apt occasion which has been selected by our prestigious pharmacology department to launch this Ecopharmacology webinar. You might have already listened to two talks, which has set the ball rolling. As we all know, ecopharmacology is a new branch of pharmacovigilance where we have always been concentrating on producing more drugs and chemicals to save the mankind. Now, with the advent of One Health, we are more conscious, or rather, we have become more conscious of not only saving the humanity and the human race, but also of preserving our environment as well as the other creatures. In order to do that, we should be using these drugs in a very judicious way. How can we do this? We know that drugs are produced from plants, animals, even from environment like minerals or using microbes. Wouldn't a day come when we exhaust these? So we have to use them judiciously as and when required. Overproduction should be stopped. And this needs tough regulations. We should be able to reuse also if there is a method of drugs which go beyond the date of expiry. We should be able to recycle the drugs which become converted into another chemical. We need novel methods to control the release of drugs through programming with bioavailability materials by incorporating them to such a way that we may we may be able to program when a capsule will become expired. Literally, not only simply expired, it is broken down into inert constituents. Think of farming and the chemicals, like the last talk has shown us the damage it creates to the environment. Think of the cytotoxic waste which can come through excreta also. And think of the medical waste like sharps, needles, gloves, masks, IV tubes, bottles, etc. All chemicals thrown into the environment and creating hazards. This is a time, I think, for all of us to think again, again, and again, and reinvent ourselves, rediscover ourselves, find out new methods, use the medicines, and stop the misuse or abuse. I wish, from my institution's point of view and from myself, all the best for the webinar. Let the discussions be good in this regard. Let's protect our environment. Let us enjoy good water, good food, good air, and thus have a good life. Thank you all. Have a nice day.
Thank you, sir. Thank you, sir,
Thank you.
for the official inauguration. As always, he supports any department activities of this kind. Now, moving on to the next talk on antibiotic use in livestock, a brief review of literature. I would like to invite Dr. S.P. Dhanya, Professor, Pharmacology, GMC Kottayam. Dr. Danya Shashtaran Palapalil, MBBS MD Pharmacology, MBA HRM. She did her MBBS from GMC Kottayam and MD Pharmacology from GMC Thiruvananthapuram. She did her MBA under Annamalai University. She joined the Medical Education Service in 2010 March and now is currently a professor since May 2021. She's a faculty at NMC Nodal Center for Faculty Development, a life member of Indian Pharmacological Society, National Association of Pharmacology and Therapeutics. She has published 40 papers in various journals with 277 citations. Currently, she is pursuing a PhD under Kerala University of Health Science, and also she is an Assistant Nodal Officer, Multidisciplinary Research Unit. Welcoming you, ma'am.
Happy morning, everyone. Today, on this occasion of World Environment Day, I take this opportunity to thank our department and the organizers who gave me the opportunity to present on the topic, antibiotic use in livestock. I'm Dr. Danya, and this is only a brief good morning, all. Hope I am audible now. Sorry for that technical glitch. Should I start from the beginning? So I'm starting from the beginning. So this is a brief review of antibiotic use in livestock. And I'm Dr. Danya. I'm not an expert in this subject. And we'll be going through the topic in a reflection model. That is what happened, so what, and what next. So this is a retro slide. We have all studied this in our grade 3 and 4. And we all know what are the food animals. And of course, they are producing food for human consumption, like the eggs, meat, and milk. So why do we use antibiotics in animals? For treatment of specific disease that we all know. Then what else? Secondly, as non-medicinal for growth promoters, there is established scientific record which shows that use of antibiotics in livestock will increase the productivity, be the size of the egg or the meat. Thirdly, as a prophylactic and metaphylatic. What do we mean by prophylactic use of antibiotics? That means that the whole herd is given antibiotic before starting of the disease. Those who at risk are given antibiotic. And what do we mean by metaphylatic use of antibiotic? That is, a few of the animals in the herd, they are having symptoms, and when we are giving the antibiotic to the rest of the herd for preventing infection, that is, these animals are healthy, and because these three are infected, the whole herd is getting antibiotic. That is called as metaphylatic use of antibiotic. Coming to the roadmap of history of antibiotic use in livestock, it all started with Prontosil in 1938, and then gramicidin was extensively used for the treatment of mastitis, and sulfaquinoxylin was used in poultry. Later, the antibiotic fermentation products that was used as a cheap alternative for the vitamin B12 supplements. And as Gafusar has already mentioned, it was used extensively as growth promoter without the prescription of the veterinarians. In plants for preventing infection, streptomycin was used, and for preventing degradation of the fish, shellfish, and poultry, tetracycline was used. The FDA put out notice that penicillin residues should be checked in milks. And mind you, this all started in the 1940s and 1950s. What happened in the 1960s and 70s is that farmers started increasingly using antibiotic for the quality of the carcass that was produced because of the hormone replacement, for preventing degeneration of the meat. And monensin was used for preventing bloating, and the hints of resistance due to antibiotic use in livestock started developing in the 1960s. Blastocidin, kasugamycin, polioxin, validamycin, all these antibiotics were used for treatment of various diseases. There was surge of non-medicinal uses in 1970s, especially in the maritime environment. And along with the introduction of organic fertilizers in the 1980s and tranquilizers in the 1990s, the use of antibiotics continued to increase in livestock. Tons of antibiotics were seen in the feed and water, along with mycelia waste, especially in Brazil, which was the largest producer of the poultry, and China, which is the largest producer of pig. And we all know that Gafusar told by 2010, there was a proper discussions by the antibiotic stewardship committees, and antibiotic reductions and withdrawal was talked about in the whole world. Actually, by 2016, the European Union banned the use of antibiotic as growth promoters. Now, the China followed suit, and what did China do? China imported the colistin to India, and in India, even in 2017, colistin was openly marketed as a growth promoter or metaphylatic. So this is not the end. This is actually the beginning. What was the beginning? Selling at the agriculture fairs or directly in the farms. The farmers who were interested with the thought of increased performance boosters, they tried whatever was available, whatever antibiotic was sold. And this is a old German term, that is Autobahn Tierarzt, that is motorway veterinarians, that is veterinarians who have never seen animals. They prescribe growth promoters sitting in the cars. So this led to divergent national regulations, introduction of antibiotic stewardship committees, and restrictions. So we have done with what happened. Now, there were a lot of increase in the social culture as well. The books by Shell with Modern Meat, the book by Rifkin, Beyond Beef, and The Antibiotic Paradox by Stuart B. Levy. These books, which are still available on Amazon, they are a war cry against the use of antibiotics in livestock. Now, so what? Dr. Hari has already mentioned the flow of drugs. Let us specifically concentrate on the flow of antibiotics. So, in the livestock, the antibiotics that they use for growth promotion or as metaphylatic or prophylactic or for treatment, they are excreted, or the animal feeds that are not consumed, and the farmyard manure, again via the excreta, they reach the soil and groundwater. And from the soil, they again leach into the main water bodies. And from there, where does they reach? They reach the plants and us. And the plants, they are consumed again by the cattle and the meat. Those who eat meat, the antibiotics reach back them. So here is the importance of One Health that everyone has been telling from the start of the webinar. So we need to use the antibiotics prudently to save the animals, us, and the environment. We know that the antibiotic that is leaching into the soil, and the soil bacteria, actinomycete, that is the source of drug like erythromycin, streptomycin, and tetracycline. And it can cause, the use of such antibiotics can cause destruction of the natural soil microbes and emergence of antimicrobial resistance, and a report of up to 8 to 15 drugs developing multi-drug resistance have been seen in the literature. And colonization and transmission of antibiotic resistant bacteria in the livestock have been seen. So what happens on colonization and transmission of antibiotic resistant bacteria among the food producing animals? So via their feces or the intestinal flora or meat consumption, mainly through the animal handlers who collect the feces, or the slaughterhouse personnel who slaughter these animals and provide the meat, through them these multi-drug resistant bacteria reaches the individual, and once they are hospitalized, there is cross infection in the hospital or via the healthcare professional. It is again transmitted to other persons, and it is transmitted to the community. And finally, the use of antibiotics in animals, it has led to gene flux, and it can affect the human health, the animal health, as well as the public health, resulting in resistance and therapeutic failures. So I don't know how many of you have noticed these statistics. How many of you are eating meat? You should know these statistics. The global trends: 45 milligram of antimicrobials are used to produce 1 kilogram of beef. 148 milligram of antimicrobials are used to produce 1 kilogram of chicken, and 172 milligram of antimicrobials are used to produce 1 kilogram of pork. This is a 2015 data, and the 2020 data is not much difference. There is only a 10 to 20 milligram difference from what is shown in this graph. So it is expected that the per capita intake of meat is going to increase to 36 kilogram per year. And you can just calculate what is the extent of damage that is being done. So the top 5 countries with the largest shares of antimicrobial consumption in the food animals, they are the China. Even though the China restricted the use of growth promoters as antibiotics as growth promoters in 2016, and by 2020 they have cut down it, still China is the largest country with the largest share of antimicrobial consumption in the food animals, followed by the US, Brazil, India, and Germany. We can see from this figure that in the United States, 80% of the annual antimicrobial consumption is used in the food animals. And coming to the hot spots of antibiotics, yes, you are seeing it rightly. The Asia is the hot spot of antibiotic use in the food animals. And this decreased violet color in Africa might be due to underreporting, because the reports from Africa are still less. And the projected use of antimicrobials in 2030, we cannot see India here. India definitely is going to have an increase in the antimicrobial use by 2030. Let's go on to the statistics. China will still top, but we can see that from 2020 to 2030, there is only a 1% increase, while in Pakistan, we are expecting a 44% increase, and India a 5% increase. So what should we do? So we are going to the next session. What next? So as medical professionals, we should know about the proper use of antibiotics in animals. So for that, we need to know how to categorize the antibiotics used in animals. This is the European classification, and we know that the WHO has classified the use of antibiotics in human as the AWARE classification, that is the access, watch, and the reserve. And here we have the ABCD classification. A is for avoid. It is not authorized in the veterinary medicine, and it should not be used in livestock. It might be used in the companion animals if it is a necessity. B is the restrict. That is, it is important for human use, restricted to mitigate risk to public health, and only when the category C and D fail. And the C is the caution group. There are alternatives in the human and some veterinary infections which don't have D alternative can use the C category. And finally, the D, actually it is a P category, that is a prudence category. That is the first line for the treatment of infections in animals. And we have to use prudently only when medically needed. That is, we should not use, or the veterinarians should not use it as growth promoters, or should not use it as prophylactic or metaphylactic unless indicated. So these are the drugs coming under the avoid category. We can see the anti-TB drugs, piperacillin, tazobactam, meropenem, doripenem, linezolid, all coming under the avoid category. What about the restrict category? The drug that Gafur sir has been on and on telling, colistin, it is coming under the restrict category, and it has been widely used as a growth promoter in India. And the fluoroquinolones, norfloxacin, enrofloxacin, pradofloxacin, these are again coming under the restrict category. And cefoperazone, it is again coming under the restrict category. And aminoglycosides, chloramphenicol, clindamycin, erythromycin, the macrolides, the beta-lactam antibiotic along with the beta-lactamase inhibitor, it is again coming under the caution category. And finally, which are the antibiotics that can be used in the animals? That is the prudence category. That is our ampicillin, amoxicillin, tetracycline, cloxacillin, benzathine penicillins, and sulfonamides, metronidazole, bacitracin, fusidic acid, and furosemide. The statistics shows that the most widely used antibiotic in animals is tetracycline, followed by the beta-lactams or the penicillins in particular, and fluoroquinolones and macrolides have been extensively used in the animals. Now, the importance of route of administration and formulation to be chosen for preventing development of antimicrobial resistance. We should know that the local individual treatment is the most acceptable therapy for treating the food animals. That is, if there is mastitis for udder injection. Then comes the parenteral individual, followed by the oral individual treatment. And the group treatment, that is the injectable, the oral group medication mixed in water, and finally, the oral group medication via feed or premixes, they should be maximally avoided. This is a chart showing the various antibiotics that could be used in various diseases seen in animals. And what can we do? The WHO has categorized the pathogens, prioritize the pathogens to guide research and development of new antibiotics. We as modern healthcare professionals, we should understand that these are the organisms, the carbapenem-resistant Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacteriaceae, which are grouped under the critical priority and for which the development of antibiotics should be looked for. So coming to the final, the 10 commandments of an antibiotic smart farmer. This was proposed by the REACT group, of which Gafur sir is very much a part. It is actually a proposal by the CMC Vellore that is acting against resistance and of antimicrobials. We should consider antibiotics as valuable resource and use it prudently for the health and survival of the human race. We should not use antibiotics as growth promoters. We should not use antibiotics routinely for prevention of disease and restrict usage only for treatment of affected animals. We should follow appropriate withdrawal periods for antibiotics used for treatment before harvesting and marketing of the farm produce. And we should ensure the feed used in the farm is free of antibiotics and procured from good quality manufacturers. We should ensure that adequate biosafety measures are followed and clean and hygienic environment is provided to the animals, thereby reducing the chance of spread of infection and also the need for antibiotics. Prophylactic vaccinations should be advised more than prophylactic antibiotic use. We should dispose the waste generated from the farm safely and ensure that it does not contaminate the water and soil. And we should ensure accurate labeling of the farm in all cases where antibiotics have been used. And we should not procure antibiotics. Actually, the veterinarians should decide that they are not going to prescribe antibiotic unless there is a medical indication. And finally, we should spread these commandments to our fellow medical practitioners, veterinarians, as well as the society. So this is my acknowledgement slide, and these are my references, and thank you.
Thank you so much, madam, for enriching and imparting us with knowledge on antibiotic use in livestock. She started with what are food animals and why do we use antibiotics in animals, flow of antibiotics, global trends in antibiotic use, categorization of antibiotics used in animals, and 10 commandments of an antibiotic smart farmer. Our take-home message is that antibiotics should be used in food animals prudently to prevent development of resistance and promote One Health. Once more, reminding you all that you can send your queries to your official mail ID so that we can forward to a resource person.
Now, I invite Dr. Anurag T. Aloysius and Dr. Neetu Mohan, junior residents of the Department of Pharmacology, Government Medical College, Kottayam, to present their paper on gaps in safe disposal of medicine. Dr. Anurag T. Aloysius is a junior resident of Pharmacology, Government Medical College, Kottayam. He did his MBBS from Sridevi Institute of Medical Science and Research Hospital, Karnataka. He has done a poster presentation in CME Salware Antibioticum on antibiotics use in multi-drug resistant organism infections, a case series.
Dr. Neetu Mohan, she has done a MBBS from Malabar Medical College Hospital and Research Center, Kozhikode. And also she has done a poster presentation in CME Salware Antibioticum on multi-drug resistant Acinetobacter infection, a case series. We welcome you guys.
Good morning, everyone. Myself, Dr. Neetu Mohan. I am going to present a study on topic knowledge regarding safe disposal of unused drugs among non-medical staff in a government medical college. So, coming to the background, a lot of dispensed medicines remain unused or left over because of adverse effects of drugs, and passing of expiry date of the drugs, and because of the physicians prescribing practices and the patients feeling better and stopping the medicine, and due to the alteration of dosage or drug by the physician, and due to dispensers practices and promotional practices by the manufacturers. So the most unfriendly drug disposal method is either flushing into sink or toilet or into the dustbin, through which these pharmaceuticals are entering our environment. So here comes the importance of ecopharmacovigilance, which is the science concerned with detection, assessment, understanding, and prevention of adverse effects related to the presence of pharmaceuticals in the environment, which affect human and other animal species. So coming to the rationale, the families and patients are in possession of unused or expired medications, and most of the medicine users remain unaware about the disposal of unused or expired medicines. So our objective was to describe the perceptions regarding the safe disposal of unused drugs among non-medical staff in a government medical college. So this was a descriptive cross-sectional study done at the Department of Pharmacology, Government Medical College, Kottayam. And we recruited 100 non-medical staff by convenience sampling, and duration of the study was 3 months from March to May 2023. We obtained institutional review board clearance, and a structured and validated questionnaire in Malayalam was given to the participants, which consisted of 20 questions, 3 domains: knowledge, attitude, and practice, about safe drug disposal methods. And once the participants filled the questionnaire, I sensitized the participants regarding the safe drug disposal methods. So coming to the response rate, we distributed about 120 questionnaires, and 100 questionnaires were filled and returned back to us. So our response rate becomes 83.33%. And coming to the gender distribution, about 59% of the participants were females, and 41% were males. Coming to the age distribution, we recruited non-medical staff between the age group of 18 to 56 years of age, and most of the participants were in the age group of 38 to 47 years. And coming to the results, the knowledge-based questions, we had 6 knowledge-based questions, and 93% of the participants had agreed that improper disposal of leftover medications affect the environment and health badly. And the second questions, the disposal method that you have heard about. And these options were the scientific or proper disposal methods, and about 31% of the people had heard about the high temperature incineration method. And coming to the expiry date, 60% had the idea, correctly stated, that last day of the month is the expiry date if the month and year of the expiry is given. And 84% did not have the idea what is the validity until the expiry date before which the medicine should be dispensed. Only 16% participants said that it is 15 days before until the expiry date before which the drug should be dispensed. And only 22% people had the idea that inhalers must not be incinerated. And only 11% had the idea about bio-waste management, that the expired and leftover medicines should be discarded in the yellow container. So coming to the practice-based question, we had 9 practice-based questions. The ways in which the participants received the medicines. 73% of the people said that, and it is either due to the result of treatment in the hospital or they purchased after the prescription by the doctor. And 90% of the participants were handling the medicines themselves at home, and 82% had leftover medicines at their home or place of stay when the questionnaire was distributed. And among the leftover medicine groups, the painkillers topped the list with a 55%. And the reason for possession of leftover medicines at the home or place of stay was self-discontinuation after the condition was resolved. 45% said that they self-discontinued the medicine after the disease is resolved. And about 61% of the patients used to keep the leftover medicines in cupboards or shelves. And coming to the main question of the day, that is, what do you do with the leftover medicines? you should return to the medical store or pharmacist. Only 11% correctly said that they are returning the leftover medicines to the medical store or pharmacist. But about 32% people said that they are throwing away it in the household garbage, either keeping it at home until it is expired or burning it or burying it. So 76% of the people always check the expiry date of the medicines, but at the same time, only 39% of the people check for the disposal instructions of the medications. This shows that there is a lack of knowledge regarding the drug disposal practices. And coming to the attitude-based questions, we have 5 attitude-based questions, because most of the, about more than 50% of the patients, participants did not know that there are proper methods for the drug disposal. And only 43% said that they are aware of there are proper disposal methods, but among that, 21% got their information through the internet. And whether if the medicine is solid or liquid, it must be returned to the pharmacist. Only 15% correctly said that they should be returned if the medicine is in solid form, but 32% think that it should be burned. Also, if the medicine is liquid, 33% of the people think that it should be buried. And 70% of the participants think that health professionals are the people who should create proper disposal of leftover medicines and expired medicines. Now, in the knowledge domain, out of 12, minimum score was 1 and maximum was 5. And our mean knowledge score was 3.14 plus or minus 0.84 standard deviation. And the mean attitude score was 0.19 plus or minus 0.51 standard deviation. And mean practice score was 4.36 plus or minus 1.67 standard deviation. And 65.9% of the males and 67.8% of females are having good practice. And 86.2% of participants between the age group 18 to 37 years and 59.2% of participants between 38 to 56 years are having good practice with a significant p-value of 0.01. Coming to the limitations of this study was done only in the non-medical staff. This limits the generalizability of the findings, and also the respondents were those who have unused medicines at the day of administration of questionnaires. And we did not take into consideration the people who had leftover medicines in the past. So any assessment might underestimate the paucity of knowledge and ill-advised behaviors of medication users in general. Coming to the conclusions, the participants are having poor knowledge, attitude, and practice regarding the drug disposal. And there's a high practice of keeping medications at home, and most disposal approaches were not recommended ones. Most of the participants disposed the drugs by throwing it away in the household garbage. And most of the people think that government, health professionals, and pharmaceutical industries must create an awareness regarding the proper drug disposal. And there is a high need of proper education and guidance for patients about disposal practices of unused and expired medicines. These are the references. That's all about drug disposal in non-medical staff. Now, over to you, Andrea.
Good morning, all. Good morning, all. So I'm going to briefly go through a study conducted in our institution titled Gaps in Knowledge Among Medical Undergraduates Regarding Safe Disposal of Unused Drugs. So essentially, the study is very similar to the study conducted by Dr. Neetu, but there are a few critical differences, especially with respect to the study participants. So coming to the introduction, so we know that unnecessary storage of pharmaceutical drugs and improper disposal is essentially an environmental threat. And this study was conducted in medical undergraduates. So what is the rationale for conducting in medical undergraduates? So they are the future of healthcare development, and they need to have sufficient knowledge to inculcate positive attitude and good practice measures in the members of the community, as well as they must act as role models and advise the people of the society on and about the safe disposal of unused drugs. And there is paucity of data regarding the knowledge, attitude, and practice among medical undergraduates. So what is the objective? What was the objective? So to describe the gaps in knowledge regarding safe disposal of unused drugs among second-year MBBS students in our institution. So this is a descriptive cross-sectional study conducted in our department. 102 participants enrolled in the study from second MBBS students, and they were enrolled by convenient sampling. The study duration was 3 months. After getting IRB clearance, a structured and validated weighted questionnaire in English was administered to the participants by Google fill-out forms. So 3 domains were assessed: knowledge, attitude, and practice. The total score came out to be the maximum score of the study was 13. And later on, the participants were sensitized about the topic. So coming to the results, total 185 second-year MBBS students were handed out the Google fill-out forms. 55.13% responded positively. That is 102 participants. The age group is from 19 to 22 years. 63.7% were females and 36.3% were male participants. So what were the results? Knowledge-based questions. The first question: can improper disposal affect the environment and health? 91.2% responded correctly that yes, it will affect the environment and health. And among the disposal methods, most of them, that is 70.6%, had heard about high temperature incineration and 52.9% about engineered landfill. They were not much aware of returning to the manufacturer or the pharmacist. So 51% got it correct that the last day of the month is the day of expiry if the month and year are given. And 87.3% of the individuals or participants got it wrong that what is the validity until which the medicines can be dispensed, which is 15 days before the expiry date. 60.8% got it correct that inhalers should not be used, should not be incinerated because they can explode and affect the incinerator or the furnace. And expired or leftover medicines should be put in yellow containers, but 66.7% of them had a wrong response. Now coming to the practice-based questions, most of them purchase or receive the medicines after prescription by a doctor or as a result of treatment from the hospital. That is 97.1% and 91.2%. And majority of the participants were handling their medicines on their own. That is 81.4%. And they said that 84.3% of the participants did have leftover medicines at home. Among the leftover medicines, the majority of people responded that painkillers were the majority of the leftover medicine, 85.3%, followed by ointments. So the reason for possession of leftover medicines, 71.6% responded that self-discontinuation after the condition resolved. That was the major reason. And most of the medicines were stored in cupboards or shelves. And what do you do with leftover medicines? Most of them keep the medicines until expired. Some of them and 58.8% of them throw away in household garbage, and 56.9% they share with their friends or relatives. 70.6% gave a positive response that they always check the expiry date, but only 17.6% responded that they always check for the disposal instructions on medications. Coming to the attitude-based questions, 55.9% of the individuals were not aware of any proper methods of medication disposal. And to the question that which method of drug disposal they should adopt if the medication is solid and if the medication is liquid. For solid medications, this majority of them told that they should either return to medical store or pharmacist, or they should throw away in household garbage, which is the wrong response. They should ideally return to the medical store or pharmacist. Even for liquid medications, 42.2% said that they will return to the medical store or pharmacist. 33.3% were ready to flush the medications in the sink. So, to the question, who do you think should create awareness for this? The 44.1% of the majority responded that the government should create awareness. Now, coming to the final results, the knowledge domain out of 8.5, the minimum score came out to be 0.5 and the maximum 7. The mean was 3.78, standard deviation 1.42. And the mean attitude score, the total score was 2, out of which the mean came out 0.44 with a 0.72 standard deviation. And the practice score, the total score was 2.5. The mean was came out to be 0.81. Standard deviation 0.57. 52% of the participants are having good knowledge. 52.3% of the females and 51.3% of the males are having good knowledge, showing the gender distribution. So what are the limitations of the study? The study was done only in second MBBS students of a single center. So it is not generalizable to all the medical undergraduates. Now coming to the conclusion, the participants are having poor knowledge, attitude, and unsatisfactory practices. And there is a high practice of keeping medications at home or room. The main reason being due to self-discontinuation of medications once the condition resolves. So we have to incorporate about safe disposal of unused drugs in the curriculum of the medical undergraduates. And we have to establish cost-effective and acceptable disposable methods for proper disposal at the local and regional levels with the help of the authorities to decrease the environmental load of drugs. These are my references. Thank you.
Thank you, Dr. Anurag and Dr. Neetu. They have outlined the actual knowledge and the common practices on the safe disposal of unused medicines in medical undergraduates and non-medical staff of our college, which can be considered as a layman perspective. Now, we have the last talk of today's session by Dr. Jinesh Joseph, Associate Professor, Pharmacology, Government Medical College, Alapura, on safe disposal of medicines. Are you really aware? Dr. Jinesh Joseph is the Associate Professor of Pharmacology, Government Medical College, Alapura. He did his MBBS and MD from Government Medical College, Trivandrum. He has 5 publications in various journals, and he is an IRC member of Government TD Medical College, Alapura, and member of IRB Government Nursing College, Alapura, and he's the CCSEA nominee for various institutions. We welcome you, sir.
Respected teachers, senior faculties, colleagues, and my dear friends. First of all, I express my sincere gratitude to Department of Pharmacology, GMC Kottayam, for providing me an opportunity to present a topic on this World Environmental Day. So the topic allotted to me is proper and safe disposal of medicines. So what is the importance of proper and safe disposal of medicines? The previous presentation, we were able to know that the knowledge, attitude, all these are less even among medical students. So when we need to dispose medicines, when usually in our home, when the after the expiry date, we will not use, we want to dispose the medicine. That is at the home level, individual level. And if you look at the institutional level, sometimes in hospitals, a lot of medicines get accumulated due to quality issues. Or recently in medical godowns, there occurs burns. So again, due to that extreme temperature, some of the medicines will not be suitable for usage. And then again in certain natural calamities like wars, earthquake, floods and all, you will get a lot of medicines as donations. And then again, due to some disruptions in the supply chain or due to improper disposal of such medication, again that will get accumulated. So all this will become a headache for not only for the doctors but also for the general community. So we should know what are the methods available for safe and proper disposal of medicines. And then we have, I am discussing this topic in the following headings. What is the importance of proper disposal of medicines? What are the various guidelines that is available for proper disposal of medicines? And what are the methods that is proposed in these guidelines? So the importance, all of you are aware, and the previous speakers told about the various issues that is related with the improper disposal of medication. The first and foremost is the water contamination, or the contamination of our aquifer. So that is the major thing that first speaker, Dr. Harishankar, has told about the various studies in which these medicines were detected in various water bodies and all. So it has a lot of environmental impact. And again, these medical substance, they are chemicals, and so they can react with other chemicals or other chemicals in the environment, and that can produce toxic chemicals, which will again we will consume through drinking water or food like that. Then, and as far as Kerala is concerned, Kerala is a very narrow state. It is a state with the 14 districts, but 44 lakes. And one recent national census on water bodies put Kerala on, that is more than 55,000 water bodies are there. So our waste disposal is a very problem in Kerala, because through this, if the waste disposal is not proper, it can contaminate all these water bodies, and that will pose serious threats to the humans and animals. Then another importance is that human health risk that the previous speakers told about, the development of antibiotic resistance. That is one important thing. Not only humans, but the animals, birds, all these are affected by improper disposal of these drugs. Then it has got legal and ethical obligations. Legal, if you dispose of waste in a, or if there is improper disposal of waste, you will be legally punishable. You can get legal issues, penalties if you improperly dispose medication. And there are also ethical issues are also there, because this drug disposal is a very sensitive issue. Suppose if at the institutional level or at the district level, if you dispose the drug in not a proper way, it can get politicized. It's a very sensitive issue. So the media will take up the issue, and it will create a lot of problems to the administrators. So you have to sensitize both the media persons and the politicians about the importance of proper disposal of medicines and pharmaceutical waste. Now coming to the second part of my discussion, that is various guidelines that is involved in the proper and safe disposal of medication. First and foremost is WHO guidelines for safe medicine disposal. So the WHO formulated all these guidelines in the year 1999. By that time, in former Yugoslavia, by around 1996, the war between Serbia, Croatia, Bosnia, so that various ethnic communities war was happening there. So that country was totally devastated, and they got aids from various parts of the world, and along with that, they got a lot of pharmaceutical drug as contribution. But they get accumulated. So the large stockpiles of drugs get accumulated, and it becomes a headache for these countries to dispose them safely. So WHO formulated these guidelines, and these guidelines are not mandatory to follow, because WHO itself is saying that these are only guidelines, and we can form a guidelines according to our own situations, like prevailing environmental regulations in a country or in the state, or according to the financial situation in that state. They can adopt a method for proper disposal of this pharmaceutical waste. And any of these methods are not 100% safe, and they are not 100% practical. But you can adopt a policy in which that is cost effective, less polluting, and that is more practical. So under these guidelines, they are saying that we can dispose most of the medications, like majority of the medication, we can dispose in a regular trash, provided the normal waste distribution in that area is proper. But as far as our country or our state is concerned, you know that it is not very proper. Recently you read in newspaper that in Kochi
that National Green Tribunal has fined 100 crore rupees for Kochi Corporation for not properly disposing the waste at Brahmapuram plant. So we can dispose in regular trash if the normal waste disposal is done in a proper way. So that is the advantage in developed countries like US, UK, Germany, Sweden. There, waste disposal is getting adequate and properly done. So in such countries, they can dispose it as a regular trash, and that municipal authorities or local bodies will take the truck and they can dispose along with the other normal waste or normal municipal waste. So it is the most used. It is the this is the one method that is advocated by World Health Organization, and then another method is flushing. Flushing, usually we practice flushing for disposing liquid medication, but you should know how to flush out this liquid medication. And there are also medicines in the flush list. So we will come to this in detail. And another very safe method is to return to the manufacturer or donor. But that is not proper in our country. But in Western countries, US and all, it is being done regularly. So that is not a headache in that developed countries. This FDA guidelines again, that is almost same truck take back programs in which the hospitals or the pharmaceutical companies will take back the expired drugs and then dispose such drugs. And there are some collection sites in various locations, so you can dispose the pharmaceutical waste in that collection site, and these local bodies will dispose it in a proper way. And mail back programs are there. You just send a courier or a courier of expired medicine to the designated centers. They will dispose that medication. And disposal in household trash, that is also we can do, provided that normal waste disposal is done properly. Now, in institutional level, what are the things we should do if the stockpile of drug gets accumulated? So we have to first constitute a team for disposal. The selection of team members is important because we need a qualified person like pharmacist or pharmacologist should be in the team who know about proper disposal of these drugs. And if the team should contain law enforcement agencies like police or judiciary officer, because they may contain controlled substance like psychotropic drugs, narcotics. So that person should also be there in that team. And there should be an environmental engineer that is aware of all of the environmental regulations and the environmental impacts of disposal. That he should also be there in the team. And there are other resource persons like normal workers for transportation, logistics. All these teams, we should select a team, and we have to assign the various roles to each of these members. That is again important. And this effective communication between team leaders, that is very important for the proper success of the drug disposal program. Then we need certain requirements. We need certain containers for sorting out these drugs for disposal. Container selection, it can be either cardboard or plastic or metal container. We can take as per our convenience or availability. And there should be a disposal time frame. We should decide, the team should decide these drugs should be disposed in what time. The details I will tell in the coming slides. And the most important thing in disposal of medication is proper sorting of medicine, because like we can sort like medication as dosage forms, like solid dosage forms, liquid dosage forms, and again solid dosage forms. We have to separate this controlled substance, narcotics. We have to separate controlled substance, and we have to label each of these cardboards or this containers. And this anti-infectives, we have to keep a separate box. And anti-neoplastic drugs, again, we have to keep it in a separate box. The other solid dosage forms, we can keep it together. And similarly, liquid dosage form, we can put separate. And again, from the liquid dosage form, we have to separate this liquid antibiotics separately, and anti-neoplastic drugs, if any, separately. We have to keep it separately. And antiseptics and disinfectants, again, we have to keep them separately. Other liquid preparations, we can keep in a same container or cardboard box. Then what are the other steps for safe disposal? We may need administrative sanction from the other higher authorities to dispose these medications. And we have to keep a record, or we have to get specific orders. And there should not be much delay in getting these paperwork and all. It should be very fast. because of this computer era and all, it may be easy to get administrative sanction. And we have the team has to prepare for disposal. They have to provide arrangements or logistics equipments for this proper disposal. And once the sorting is completed, we will be able to get an idea we have how we can dispose these drugs, because antibiotics and anti-infectives, they cannot be clubbed with the other normal drugs. So they need a separate disposal method. So depending upon the bulk of these drugs, we can decide on the method of disposal. Then for this personal protective gears should be provided to all the members of the team because these are hazardous waste. So all the members should be provided with the personal protective equipments for proper disposal of these antibiotics. Then coming to the sorting of pharmaceutical waste, some more points are important. As I already told, we can take cardboard boxes, very cheap and easily available. We have to label each of these containers, that is solid dosage forms, then solid dosage forms with antibiotics, then solids with anti-neoplastic drugs. That separate box, then controlled substance in another box. So that box should be labeled, and we have to store the drugs and sort out different categories depending on the dosage form, like solids, liquids, as I told earlier. Again, we can keep all these capsules and tablets or solid or dosage forms in the same container. Now coming to the disposal methods. Once the sorting is completed, we can decide on what disposal method we should adopt. Then as previously told in the previous sessions, we have got incineration, we have got landfills, and another minor method is chemical decomposition. First, we can study about landfill, because landfill is the common method that is followed in developing countries like India and in our state. It is mainly this landfills it is being followed. Landfill, it is mainly of three types. This landfill should be adopted if the pharmaceutical waste is less than 1% of the daily waste. So if the daily waste is around 100 tons, the pharmaceutical waste should be 1 ton. So that in that proportion, we can dispose. If it is in that proportion, we can dispose by landfill. So the pharmaceutical waste should be less than 1% of the daily waste. And this landfill is of three types. That is ordinary dumping. That is happening in this Kochi and all. Just dumping in a waste yard and not doing anything. So it is not advocated. Just ordinary dumping or unengineered landfill, that is called. And that should be a last resort in disposal of drugs. And even if we are planning that, we have to cover it with the fresh municipal waste, so that the scavengers they will not be get scavenged, or these vultures, animals, birds, they will not get diseases due to accidental consumption of such waste. So that is not properly. Ordinary landfill or unengineered landfill, it is not advocated. Then the other two types, that is engineered landfill. This ordinary landfill or open dump, another problem is it will definitely contaminate the aquifer, or aquatic system will get contaminated. Then coming to the engineered landfill. Engineered landfill, it is somewhat far better, because this area of where the dumping happen is not near to an aquifer or water field. It is away from a water body. So there is protection of water bodies is there. Then here again we have to mix with the unpalatable substance. This household trash that is proposed by WHO, I forgot to tell one thing, that is, even if we are disposing drug in normal trash, we have to cover it with unpalatable substances like cat litter or coffee grounds, so that they are unpalatable, so that this animals and birds will not get injured. So again, in engineered landfill also, we can it should be covered with the fresh municipal waste, and it should be mixed with the unpalatable substances. Then this highly engineered landfill. Highly engineered landfill, that is a ideal method for disposal by landfill. This landfill is suitable is not suitable for anti-infectives, anti-neoplastic drugs. It is not suitable. So, but other categories of drugs we can use by landfill method. This highly engineered landfill means we have to create a large pit, and we have to dispose this pharmaceutical waste in the base of that pit, and we can cover again with the fresh municipal waste around the pharmaceutical waste, and then cover each day's waste with the soil. So these three should be there, and it should be away from an aquifer, and it should be away from a water table also. So that underground this water is also protected. So highly engineered landfill means it is away from an aquifer or this water bodies, and it is also above the water table. And this pharmaceutical waste will form the base. Over this we can put municipal waste, and over this we can put soil. So this is recommended, but this is not recommended for anti-infectives and anti-neoplastics. Now coming to the encapsulation method. This encapsulation, we can do it for all type of drugs. Like this is as the name indicates, we will form a capsule of the pharmaceutical waste. This capsule is in the form of a drum. It can be either plastic drum or metallic drum. So we can put the pharmaceuticals in this drum up to 75% of the capacity. So this before putting this drugs in the pharmaceutical this in the drum, we have to remove the outer cover, because this outer cardboard boxes from these pharmaceuticals should be removed. So that can be done while we are sorting the pharmaceuticals, because that will reduce the bulk of this disposal to half. So we have to fill 75% of the capacity of the drum with the pharmaceutical waste, and rest of the 25% we can put a mixture of cement, lime and water in the ratio 15:15:5. That is 15% cement, 15% lime and 5% water, or in the ratio 3:3:1. In that ratio we can put this mixture over the top of the 75% of the pharmaceutical waste we are putting in this drum. We can over this we can put this mixture in that particular ratio, and then we have to seal the drum. If it is a metal drum, we have to weld the drum, and that this process is called encapsulation. And then this encapsulated drum or encapsulated pharmaceutical waste we can dispose by landfill. Again, this drum should form the base of the landfill. Above that we have to cover municipal waste, and we can dispose in that way. And another method in which we can dispose or pharmaceutical, or we can by this encapsulation or inertization, we can dispose even the anti-infective drugs and anti-neoplastic drugs. Along with the other drugs also we can dispose. Then inertization means, inertization we have to ground all this. We have to take the pharmaceutical from the blisters. We have to ground this in powder form by a grinder or by a rod roller. And we have to take again the same cement, lime, and this water. But here, this pharmaceutical waste should be 65% of the total quantity. 15% cement, 15% lime, and 5% water. And we have to mix, like that we are using a concrete mixture. We can mix all these together with the water, and mixing can be done in a concrete mixture. So that will form a homogeneous paste, and that will get these pharmaceuticals will get inactivated in that, and then we can dispose this homogeneous paste in the concrete mixture to a landfill in which normal waste are disposed. And around and above that we can put municipal waste, and we can dispose this pharmaceutical waste. So inertization is a very comparatively cheap process. We can easily done in our settings and all. But only thing is, the workers or those who are doing this procedure, they should have full personal protection like mask, because these powders when grounding and all, these powders get inhaled. So to prevent occupational hazard, they should use all these protective wears, and then they can dispose this in the landfill. Now coming to the one easy method is flushing. Flushing, one we should know, we should look into some important thing is that usually some drugs are in the flush list. That is, we can dispose opioid analgesics by flushing, like morphine, pethidine, codeine. All these opioid analgesics, if these solid forms, we can dispose it by flushing. Then liquid preparations, we can do flushing. But this anti-infectives and anti-neoplastics are we should not do by flushing. Other liquid preparations like antiemetics or antacids like that, we can do by flushing, but it is contraindicated for anti-infectives and anti-neoplastics. This liquid preparation, again, we have to dilute with the large quantities of water. We have to dilute it, and we have to dispose in small quantities. you should not flush out all these diluted quantities at once. We have to dispose in small quantities only. We have to dispose these liquid preparations. And disinfectants again, we should dilute. Otherwise, it will antiseptics and disinfectants. It will kill the normal bacteria that's necessary for decomposition of the sewage. It will get destroyed. So that is the decomposition will be a problem. If you want to dispose disinfectants and antiseptics, it should be again diluted, and we have to dispose or flush it in a very small quantities. And this WHO is advocating that even if the disinfectants undergo expiry date, they will lose some potency, but they will not be completely inactive. So we can again use these disinfectants even after the expiry date, because usually we are using disinfectants in a dilution. So we can adjust the dilution and we can use disinfectants even after the expiry date by adjusting the dilution. So that can prevent the disposal of disinfectants even after the expiry date. So that is one thing advocated by WHO. Then this anti-infectives, if there is no other option, we can do by flushing. But what we have to do is that we have to dilute the anti-infectives and keep it for minimum 2 weeks. Keep it in our home or institution for after dilution. We have to keep it for minimum 2 weeks, and then we have to flush it in small quantities. And flushing again, one more thing is important. We have to do flushing ideally when there is fast running water bodies are there. In our setup in Kerala and all, this June and all, monsoon will start, and their water bodies will be flooded with the water. So that is, if you are planning to dispose of pharmaceutical by flushing, plan it in monsoon time. So this, the one slide I told, the team can decide on the time in which pharmaceutical waste should be disposed. So if they are planning to dispose by flushing, they can do it even in rainy season. Otherwise, if you do it in flushing in summer season when there is drought, there will be stagnant water that will produce harmful effects. So in only fast running water only, in rivers and all, the sewage will be get properly drained and it will get diluted. So that is about flushing. And another important method is incineration. Incineration, we can dispose most of these medicines by incineration. But only thing is, it is a very costly thing. We have two types of incineration. That is high temperature incineration, and that is in which temperature is more than 850 degrees Celsius up to 2000 degrees Celsius. So that is the ideal incineration. We have to ideal incineration method. We have to dispose the pharmaceutical waste, and this incinerator should contain 2 chimneys. 2 chimneys should be there. Why these 2 chimneys needed? Because if you heat these pharmaceutical waste in one chimney, they become these pharmaceutical toxins or become aerosols. And if you then they will go to the second chimney. There again they are subjected to very high temperature, and then they will get inactivated. Otherwise, if one chimney is there, that aerosols will go to the atmosphere. It can get inhaled, so it is a problem. So then that's the ideal method. High temperature incinerator with the 2 chimneys. Then if that is not available, that's a costly thing. Usually in our municipal waste in waste disposal areas, there is medium temperature incineration. This medium temperature incineration means the temperature is less than 850 degrees Celsius. Here, along with the municipal waste, we can dispose, but not anti-infectives and anti-neoplastic drugs. They should not be disposed by medium temperature incineration, in which normal municipal waste is getting incinerated. But we can dispose other waste if that is less than 1% of the total. In the ratio 1:1000. One is in that ratio, we can do medium temperature incineration. But this high temperature incineration is recommended for disposal of pharmaceutical waste, and in that is not financially feasible in developing countries. So the WHO is advising the use of incorporating industries into disposal of pharmaceutical waste, like cement manufacturing centers, like cement plants. They have got that's called cement kilns, or we have got thermal power stations. So here they have got this very high temperature burning of these fuels for getting cement or electricity from thermal power stations. So we can get an agreement, or we can sort their help of cement manufacturers, and we can dispose this pharmaceutical waste along with the normal fuel they are using to attain this high temperature for manufacturing cement or electricity from coal. So we can, that is a very practical and feasible method in our state or in our country, because a lot of cement factories and thermal power stations are there. In Kerala itself, we have Malabar Cements in Palakkad, and we have an NDPC in Kayangulam. So we can sought their help in disposing pharmaceuticals by waste with the help of industry. So here in these factories, the complete disintegration of this waste occur, and some pollutants may get absorbed. Then we can later remove these pollutants. Then, if this incineration is not available for disposing anti-neoplastics, if only for anti-neoplastic, there is another method called chemical decomposition. If there is that incinerator or cement factories or thermal power stations are not available, we can use this method, and we can here we can inactivate the anti-neoplastic drug with a chemical, and according to the manufacturer's recommendation. But the only problem is that it is a very slow process, very tedious process. We need the presence of a qualified chemist, and again we need time, and we need it's a very tedious process. So if it is more than 50 kilogram, it should not be done. If it is, it should be done if it is less than 50 kilogram, because it's a very slow process. It's a very costly process. It is for the disposal of anti-neoplastic waste. Now coming to the least preferred method, as I told in the beginning, this ordinary landfill or ordinary dumping, that is not at all advocated. And if it is a last resort, if we want to do it, the pharmaceutical waste should form the base, and it should be covered immediately with the fresh municipal waste. And we have this low temperature burning, that is along in our households and all, we will burn normal paper and all. Along with that, we will burn this. If you burn this pharmaceutical waste along with the normal burning, that will create toxins, it will get inhaled aerosols. So that is not at all advocated. Low temperature burning is not at all advocated. Then for like disposal of ampules, like you know, the ampules are something get expired. What you should do is, we have to put all the ampules in a metal drum. We have to crush the ampules, and we can filter these glasses from liquid, and we can separate the liquid either by flushing, by dilution, and if it is anti-infectives, we can do by encapsulation. This ampule should never be burned, because it can get exploded in high temperature. And again, this IV fluids and all, we can dispose by flushing after removing it from the PVC packing. That can be recycled. So that is regarding. Then we have about inhalers and canisters, we can go for encapsulation. That's the ideal method for inhalers and capsules. Now, coming to the last portion, that is how we can prevent reduce pharmaceutical waste. We have to, if it is in a hospital and all, we have to carefully examine the expiry date. The pharmacist or the supervising officer should look for expiry date. Now, due to computerization, it is not an easy problem. And if it is nearing expiration date, we can dispose the drug to the needy institutions, and in that way we can reduce the disposal of pharmaceutical waste. And in household level, we don't purchase unnecessary medication or purchase only the medication needed. So that method we have to adopt. In that way also we can reduce pharmaceutical waste generation. Now, to conclude, it is everybody's responsibility to create awareness regarding proper and safe disposal of medication, because it will produce a serious threat to the environment, as we discussed today. So again, in curriculum also, we need to incorporate, or we need to put awareness to medical students, doctors, doctor communities regarding proper drug disposal methods. So that also we should we should spread at a community level also. We should spread awareness to our policy makers, this panchayat members, because now in Kerala we have this Haritha Karma Sena. They will collect these drugs once in a year or twice in a year. They will collect all these MD or expired drugs. How they dispose that, I don't know, but they are collecting all this medication by charging a nominal fee of ₹50. So we can give advice to them for proper disposal of this medication and proper medication use, like not purchasing excess amount of medicines that we can reduce the usage of this medication. So that's all about this topic on safe and proper disposal of medication. Once again, I thank you. I am grateful to Department of Pharmacology for providing this opportunity. Thank you.
Thank you, sir, for the excellent presentation. Sir enlightened us with various protocols involved in disposal of pharmaceutical waste. I'm sure that his words have enhanced our awareness on safe disposal of drugs, and we will be able to choose the appropriate method according to our prevailing situation. Now, I invite Dr. Sabina K. Madam, Professor and HOD of Pharmacology, GMC Kottayam, to hand over the memento and certificate to Dr. Jinesh Joseph. Thank you, madam. Thank you, sir. Requesting all to turn on your cameras. We are planning to take a group photo.
Kindly requesting all of you to turn on your video cameras as we have to planning to take a group photo. So on behalf of the Department of Pharmacology, GMC Kottayam, I would like to thank the distinguished speakers for not only sparing their valuable time, but also for enlightening us with their commendable talk on the subject. We would also like to thank all the delegates for accepting our invitation with huge enthusiasm. E-certificates will be mailed to all delegates within a week. The recorded session of the webinar will also be uploaded soon. Thank you all once again.